All right, so as I was saying, our talk is about migraine prevention, but before we get into all the specifics of the different sorts of preventive treatments, we're just going to talk a little bit about some migraine statistics and go over some basics about how we diagnose migraine. So you all know, as well as I do, that migraine is very, very common and very disabling. There's a global prevalence of nearly 15%, which is really a staggering number when you think about it. 1 in 7 people in the world are affected by migraine. That's huge. It's 3 times as common in women as it is in men, and that likely relates to the hormonal triggers that many women experience. And that comes out to about 18% of women and 6% of men, which again is an enormous number of people that are affected by migraines. It's more common than diabetes, asthma, and epilepsy combined, and is the 7th most disabling disorder amongst all diseases. Amongst neurological diseases, it's associated with the most disability. In addition to all the disability, there's associated financial burdens and costs that are associated with migraine. This relates to healthcare costs as well as lost productivity that is due to missed days of work. Even on those occasions when someone can actually get to work with a migraine, their productivity and quality of work is reduced, and that also leads to lost productivity. Despite all these statistics, migraine remains underdiagnosed and undertreated. There are a lot of potential reasons for this, but I think probably the most important and pervasive is that a lot of people still don't recognize migraine as a real medical problem. I think they think it's purely stress-related or purely a psychological issue, when in fact we know that it's a true neurological disorder. We have a much better understanding about its mechanisms and pathophysiology now, and although we don't have a cure for it, we do have a lot of treatments that can significantly improve things for a lot of people. And I think that's a real driving force for initiatives like Migraine Awareness Week. That we're trying to increase education about migraine, not just to patients and the general public, but also to healthcare professionals, ranging from medical students all the way through to advanced trainees, GPs, and specialists. All right, so before we can think about treating migraine, we need to be able to identify and diagnose it. So the International Headache Society has this whole classification system that we use to diagnose all the different types of headache disorders. So what we have up here is their formal criteria for diagnosing migraine without aura. So by definition, in order to have a diagnosis of migraine, someone needs to have had 5 episodes of migraines, which last for 4 to 72 hours. Those headaches need to have 2 of the following 4 features, which are unilateral location, throbbing quality, moderate or severe intensity, and worsening with movement. In addition, you need to have nausea and or vomiting, or light and sound sensitivity. About 1/3 of people with migraine have neurological symptoms that occur before or during a migraine. These are referred to as auras. They're usually visual, sensory, or language related. So visual symptoms can include flashing lights, wavy lines, or blind spots. Sensory symptoms can be numbness or tingling, and language disturbances are usually described as an inability to say what they want to say. So they just can't seem to get the words out. The aura symptoms usually develop gradually over 5 minutes and typically last for 5 minutes up to 1 hour. And the headache phase of the migraine will usually start either during the aura or within an hour afterwards. All of that has seemed like a lot of detail and very difficult for a lot of people to remember. So a simpler screening tool was developed to aid in recognizing and identifying migraine. So it's called ID Migraine, and it's based on 3 of the major features of migraine, which are nausea, disability, and light sensitivity. So if someone answers yes to 2 or 3 of those questions, then there's a very, very high likelihood that they have migraines. Most people with migraines have what we call an episodic pattern, meaning that the migraines will occur here or there or just once in a while. For most people, that pattern stays stable or even improves over the long term. Unfortunately, there is a subset of people with migraine who have headaches and migraines that evolve and increase over time. When they get to a point when they have headaches on 15 or more days per month, 8 of which meet criteria for migraine, then we consider that they have evolved from episodic migraine into a chronic migraine pattern. Not surprisingly, chronic migraine is associated with more disability, lower quality of life, and higher levels of anxiety and depression. Not only that, it is more difficult to treat than episodic migraine, and so the best way of treating chronic migraine is to try and prevent it from occurring in the first place. So we do know that there are some risk factors for chronification of migraine, which we have listed here. Medication overuse is probably the most important one. That refers to using too much acute treatment, which are those medications that you take when you have a headache. So that would be your Panadol or Panadine or your triptans. So we find that when people are using those more than 2 or 3 times a week, over time they develop this more chronic pattern of headaches and migraines. And it's a very big and pervasive problem in the headache population, and something that we're really trying to educate the public as well as healthcare professionals about as well. I won't say too much about it because I think we've already had a lecture this week which addresses medication overuse headache and rebound headaches, but that is something that we're always looking for and trying to advise patients to reduce. Other risk factors for developing chronic migraine are listed here as well, and many of these are modifiable and can be improved or addressed so as to reduce the likelihood that someone will develop a more frequent or chronic pattern of migraines. And that's part of what we're doing when we're thinking about preventive treatments. We're trying to not just treat the current state of affairs and the number of headaches that the patient is currently having. We're also trying to prevent further progression. All right, so broadly speaking, when we think about migraine treatment, there are 3 main categories. So we have lifestyle modifications, and then we have acute treatment, which are those things that you take when you have a migraine, and then we have preventative treatments, which are things that you would take every day or do on a regular basis to reduce your frequency, severity, and duration of headaches. So everybody qualifies for lifestyle modifications and acute treatments, and people in certain circumstances would qualify for preventive treatments. So if someone is having migraines that significantly interferes with their daily routine, then preventive treatment would certainly be warranted. And that's usually if someone is having 1 or more migraines per week, although for some patients, 1 or 2 migraines per month might be too many. If their acute treatment doesn't work very well, or if it's associated with side effects, or if for any reason they have contraindications to the usual acute treatments, then we would need to consider preventive treatment as well. And patient preference refers to how the patient feels about their current headache pattern and whether or not they think that they would benefit from preventive treatment. So as I said, there are some people that have 1 or 2 migraines per month, and for them that's too many. All right, and so when we're thinking about preventive treatments, we're looking for something that reduces the frequency, severity, and duration of migraine attacks. We also want to reduce the associated disability. We want people to be able to do the things that they want to do or need to do. And of course, we want something that has very few side effects. And this has often been very challenging. It's sort of like a golden trifecta that remains elusive for a lot of people. Unfortunately, for many years, the options that were available to us didn't work very well or were associated with really troublesome side effects. So that's been a major gap in migraine treatment for a long time. People are having very, very frequent and disabling migraines, but unable to find something that will be effective in reducing that or improving that pattern without a lot of side effects. So we have a lot of different types of preventive treatments available to us. I think we often think firsthand about medications, particularly with the newer anti-CGRP monoclonal antibodies that have become available in recent times. There's a big focus on medications. But there are numerous non-drug options that are available for migraine prevention. And in particular, I can't emphasize enough how important the lifestyle modifications are. They not only promote a healthy lifestyle, but they allow people to be more active participants in their migraine care, and sometimes some very simple changes in daily routines can make a big difference in the migraine pattern. So we'll talk about lifestyle modifications, and then we'll go over some of the conventional migraine preventions, then discuss BOTOX, as well as the new anti-CGRP monoclonal antibodies. We'll also touch on some complementary and alternative treatments, and a little bit about neurostimulation as well. All right, so lifestyle modifications can make a very big difference in a migraine patient's migraine pattern. So these are based on the premise that migraine patients tend to be very, very sensitive to changes within their body and within the environment. And assuming that many of you here suffer from migraines, you probably know better than I do that any little change from your day-to-day routine or status quo can trigger migraines. So many of the things that we recommend are intended to help people maintain a regular routine. So regular aerobic exercise can be helpful. Doesn't have to be marathon level training, but we usually recommend some form of cardio exercise a few times a week, maybe about 30 minutes or so. Regular sleep also makes a big difference. I think many people recognize that too little sleep or sleep deprivation can often trigger a migraine, but the other side of it is that too much sleep can also be a trigger for a lot of people. And that's a good example of how something that's different from the normal routine, even if it's positive, can actually be a migraine trigger. So a lot of people feel that they don't get enough sleep during the week, and then they want to sleep in on the weekend to catch up, only to wake up and find that they've got a raging migraine. So we recommend that people try and go to bed and wake up at roughly the same time. And all the other recommendations for sleep hygiene apply here as well. We discourage devices or too much TV before bedtime, and try and maintain a regular routine so that your quality of sleep is optimized. Hydration is a very basic recommendation that often falls by the wayside in our busy lives. Dehydration can trigger migraines, so staying well hydrated and keeping a bottle of water on you can also be helpful. Regular meals can also make a big difference, particularly for people in whom hunger is a trigger. In those patients in whom a skipped meal or hunger can trigger migraines, we often recommend a snack in between as well. In general, we would say that something that's relatively low in carbohydrates and higher in protein is better, because fluctuations in blood sugar can be a trigger for migraine as well. And again, it doesn't have to be a huge slab of steak. It can be, a handful of nuts for a snack, or fish or legumes or things like that. But having some protein with each meal can help to keep your blood sugar stable and potentially avoid other migraines. Caffeine is a little bit tricky, especially in some place like Melbourne, where it's a big part of the social culture. So usually for most people, 1 coffee a day is fine, but when you find that you're drinking more than that on a regular basis, that's probably too much. Caffeine can actually be associated with a rebound type of headache in the same way that overuse of acute treatments can. So people sometimes find that when they're drinking more and more caffeine, they might find that they're having, more and more headaches. And a good way to tell if you're having too much coffee or caffeine is if you have a withdrawal headache, if you miss a coffee. So that's usually a good indicator that you're having a bit too much. Caffeine, when used, when consumed in smaller amounts, can also be used as an acute treatment. So many of you will have found that a coffee or a Coke can actually help if you have a migraine. And that likely relates to the effect of caffeine on blood vessels, and it also aids in the absorption of some of the migraine treatments that can be used for acute treatment. So that's all the more reason to try and limit your caffeine intake. If you're using too much of it, it can actually cause more headaches, but if you're using it relatively infrequently, you can actually use it as an acute treatment on those occasions when you have migraines. Dietary triggers are a little bit tricky. So we get a lot of questions about foods to avoid or migraine diets or things that are well established as dietary triggers for migraine. And I think there are a lot of migraine diets out there and long lists of things that should be avoided. I tend not to buy into that too much. I think if you followed some of those diets or restrictions, you wouldn't be eating much of anything because the lists are long and varied. In general, I would say that the closer something is to its natural form, the better. We try and avoid things that have a lot of additives and preservatives because some of those things can trigger migraines. Alcohol is a well-known trigger for migraine, and a few other things like MSG or nitrates that are associated with cured meats or deli meats can also be triggers, as can artificial sweeteners. But apart from that, we don't really have any strong evidence to indicate that there are certain groups of foods or other foods that are convincing headache triggers. So each person may have something that seems to trigger their migraines on a regular basis, but that can vary significantly from one person to another. It's also sometimes a little bit tricky to assess whether or not something is really a migraine trigger because triggers are sometimes inconsistent, so something may not always trigger a migraine. The time frame for triggering migraines can also vary, so you don't know if it's something that you ate an hour before or the day before. That might be a trigger as well. So I don't think that a lot of the reported triggers are applicable to most people. We briefly mentioned alcohol, but we do know that that does seem to be a pretty consistent trigger for a lot of people, and that likely relates to its effect on blood vessels and also the way that it can disrupt sleep. And obviously recognizing what your triggers are can be helpful. There are some people that think that recognizing and then sort of trying to prime or subject yourself to the triggers to try and desensitize oneself can be helpful. I'm not sure how valid that is. I think it's probably better to identify your triggers as best as you can and then try and avoid them where possible. All right, so we have our list here of conventional preventive medications. These have been used for a long time, and I think sometimes, especially in recent times with newer treatments available, I think we haven't been entirely fair to a lot of these things. A lot of them actually do work pretty well for some patients. We do have pretty good track records, particularly for beta blockers, tricyclic antidepressants, and some of the anti-epileptics, particularly topiramate and sodium valproate. The problem is that not everybody responds to them, and a lot of these things are associated with significant side effects, and that's really limited their use. And part of the reasons that they don't work very well or very consistently for a lot of people with migraines is that they were not actually developed for people with migraines. So they're all things that were made initially for other indications like high blood pressure, seizures, or depression that were sort of incidentally or indirectly found to be helpful for migraines. BOTOX has gotten a lot of attention in recent years. It's been around for a while for lots of other medical indications, and first came to the attention of neurologists and headache specialists probably in the 80s, when a lot of ladies who were having cosmetic procedures found that their migraines were significantly improved. So we've actually been using BOTOX for a while and getting pretty good results. With the PBS approval a few years ago, uptake has increased dramatically and has now become standard of care for people with chronic migraine who have not responded to 3 or more of the traditional preventive treatments. So it is on the PBS for chronic migraine, but you do need to have fulfilled certain criteria. You need to have tried or have contraindications to 3 of the standard preventives, and medication overuse needs to be addressed as well. We do have a specific protocol that we use for the BOTOX injections, which is different from what cosmetic surgeons would use for wrinkles around the face. The protocol is based on large-scale international studies that were conducted over the past decade or so that have demonstrated a significant decrease in headache days in people who undergo treatment every 3 months. So it does seem to work very well for a lot of people, and I've had quite a lot of success with it. I think for a significant number of patients with chronic migraine, it's been life-changing in a way that none of the other medications were. It is something that does need to be repeated every 3 months for a period of time. If people are doing very well and there's not any obvious wearing off towards the end of that 3-month period, we can sometimes increase the injection interval out to 3.5 or 4 months, and eventually we can hopefully even stop it in some patients. And in order to continue with it through the PBS, patients need to maintain a 50% decrease in their headache frequency compared to their baseline. We do often get a lot of questions about where the injections actually take place. So we do injections in the forehead, temples, back of the head, neck, and shoulders. It comes out to about 31 injections, which sounds like a lot, but it's a small needle and it goes quickly, and most people find that whatever discomfort they have during the procedure is offset by the benefit, which is usually maintained for that 3-month period of time. So we've had very good results from BOTOX. It does seem to be very well tolerated. People also like it because it doesn't involve daily medications nor any of the cognitive sorts of side effects that are often associated with the other preventive treatments. All right, so next we have the anti-CGRP monoclonal antibodies, which have gotten a lot of attention in the past year or so since they've become available in regular clinical practice. It's also caused quite a lot of excitement in the headache world, understandably, because they are the first migraine-specific disease-targeted treatments to be developed. So CGRP stands for calcitonin gene-related peptide. This is a protein or neuropeptide that we think has a big role in the migraine mechanism or pathophysiology. It's involved in the dilation of blood vessels, the inflammation in the coverings of the brain that occurs during a migraine, and also the perception of pain itself. So these drugs are actually antibodies to this protein or neuropeptide. They serve to sort of take it out of the equation or take it out of the system and prevent it from working. So in theory, they could potentially shut off migraines or turn them off or significantly decrease their frequency, severity, and or duration. So we've got 3 that are in various stages of approval here in Australia. The first is Aimovig, which is irenemab. That one is slightly different from the other 2 in that it's an antibody to the CGRP receptor rather than the CGRP protein itself. So that became available late last year through various programs sponsored by Novartis. And so far, we've had pretty good results with it. A lot of people are experiencing a significant reduction in their migraine frequency and severity. I can't say it's worked for everybody, but there does seem to be a substantial portion of people who do respond well to it. Another plus about it is that this whole, Aimovig and the whole class of drugs is very well tolerated. They are associated with some injection site reactions because they are monthly or quarterly doses, but again, they don't have a lot of the side effects that are associated with conventional preventive medications like cognitive slowing, fatigue, dizziness, weight gain, and all those sorts of things. The other benefit is that they tend to work quickly. We're seeing a response within a month, usually, for those patients that respond to it. And that's significantly faster than with conventional preventives, which often take weeks or months before they reach their therapeutic effect. The other another plus for these medications is that there's a standard dose. So there's usually 1 or 2 doses available for the drugs, and so you know what the right dose is. There's not a lot of fiddling around with titrating or tapering to find the dose that's going to be effective. So Aimovig at the moment has been available through product familiarization programs and 3-month free trials through Novartis. They are in the process of seeking PBS approval, which you may have heard was recently rejected again at the July PBS meeting. So they're going to resubmit for November, and we'll have to wait until December to see what happens with that. Emgality is the next one. That's galcanezumab. They actually received a PBS recommendation a couple of weeks ago, which is very exciting. However, there was a condition or some sort of restriction relating to costs. So at the moment, I think they are in the process of working out an arrangement, and it remains to be seen when or how it will be available. But hopefully it will be soon. The third one is Ajovy, which is fremonezumab. That one is in the process of seeking TGA approval, and hopefully that will come through in the next month or so, or next month or 2, or by the end of the year. Once that happens, I believe they do have a product familiarization program that has been developed, so hopefully patients will be able to try it through those programs, even if they don't have PBS approval as yet. Ajovy's also a little bit different from the other 2 in that it has options for monthly and quarterly dosing. The other 2 are available as monthly injections. Neurostimulation is another form of preventive treatment that has recently emerged in the last few years as a potential option for patients. These target certain nerves or parts of the brain that we think are involved in migraine. And they act by modulating or modifying the pain system through electrical currents or magnetic impulses. So at the moment, there are 3 options that have been developed and are available to varying degrees. So the first is transcranial supraorbital stimulation, which is the Kefali device. You may have seen it before. It looks like a sort of a Wonder Woman band that you wear on the forehead, and that acts on the supraorbital nerve, which is a branch of the trigeminal nerve, which is the nerve that we think is responsible for migraine. So the Kefali device has at least one well-controlled, well-designed study that shows a decrease in headache days in patients with episodic migraine. There is some suggestion that it might be helpful for people with chronic migraine as well, but the evidence is not as strong. The next option is the vagal nerve stimulator, which is the gamma core device. Again, it has been studied for chronic migraine, but in open label trials, and so far the results haven't been all that convincing. It's possible that it might be helpful in reducing frequency and severity in patients with chronic migraine, but we don't really have definitive evidence of that yet. Transcranial magnetic stimulation works by possibly decreasing a process called cortical spreading depression, which we think is the mechanism behind migraine with aura. And so they potentially have a role in migraine prevention, as well as possibly acute treatment for migraine with aura. But again, we don't have very strong evidence as yet for this. All that being said, all 3 devices seem to be very safe and well tolerated, and there is something to be said for that. So that is something that we might consider trying in patients that, for whatever reason, have been unable to take or tolerate any of the other options. And I think it's potentially beneficial to consider these things in addition to other preventive treatments if someone is on something else and is having some improvement but still getting more migraines than they would like to be having. So there is a potential role for it in migraine prevention at the moment. So lastly, we have some complementary and alternative options that can be helpful for migraines. In particular, there's increasing evidence for some of these behavioral treatments, particularly CBT, relaxation therapy, and mindfulness meditation. All of these help patients to better understand their response to the migraines and stress itself, and it allows people to have a bit more sort of control over their migraines and their treatment. And I think we're becoming increasingly aware of this mind-body connection and the role for some of these behavioral treatments. Biofeedback also has some good evidence, but I have not found that to be all that readily available here. That's a process by which people are able to assess their stress response and then learn ways and mechanisms to reduce that. We often get a lot of questions about nutraceuticals and supplements. And we do have some good evidence for some of them, particularly magnesium, riboflavin, and CoQ10. All of them have been shown in some small studies to reduce migraine frequency when used as a daily preventive. Melatonin can also be helpful as well. Previously, there was some suggestion that something called butterbur could be helpful in migraine prevention. Unfortunately, a lot of the available preparations have components in them that were associated with liver toxicity. So that's fallen out of favor to some degree. I think there are some butterbur supplements that are certified as not having those liver toxic components, but nonetheless, I think it's probably better to avoid it at the moment. Acupuncture has been shown to be beneficial as well. Initially, there was some suggestion that sham acupuncture is just as effective as true acupuncture, but we've had more studies in recent times to indicate that true acupuncture is more effective than sham acupuncture. And we are finding that many patients do seem to respond to this as well, particularly when done over a duration of at least a few months. I've included manual therapies here as well with a question mark because this is something that we also get a lot of questions about. These have been very difficult to study because there are so many different types of physical or physio-type therapies, so they've been difficult to compare and also difficult to compare against a placebo. For the most part, we haven't seen very convincing evidence for a lot of the available manual therapies. But again, I think that there are many patients who do seem to benefit from physiotherapy or massage or things like that, and I'm more than happy for patients to continue with that if they have found that that's helpful. I usually just caution against anything that involves high velocity neck manipulations. This is sometimes used in chiropractic maneuvers, but for the most part, a lot of the manual therapies that people try for migraine seem to be fairly safe and well tolerated.